this other room, your price moves to 100,000. If you go to this other room, it's 150. If you go to this luxury room, it's 200.
Yeah.
So what does that tell you? In terms of nurses who deliver you, in terms of the medication, in terms of all the clinical aspects, you will get the same thing. But because of where you are spending the night, the prices change. So the same way for SHA, the tariff is open. There will be facilities that will say, we are okay, this is enough to pay the doctor, the hospital, the anesthetist, whatever it is. If you look at dialysis, the same. They will tell you walk in, walk out. Chemo, they
Again, you're muted.
Another question for you, Daktari. How do we know where these level 2, level 3, and the selected level 4 hospitals that provide primary health care are, and how do we register? And another one that is related to that, is the government planning to equip the primary health care facilities with enough medics and medicines?
level 2, 3, and 4 is not the public. So it's also private and mission. For example, Penda Health is part of the level 2, 3 network.
Yes.
In terms of the facility, the government equipping, if you came earlier, you would have listened, you would have heard that I talked about FIF. FIF is one of the things that will address the issue of human resource and the issue of equipment for those public facilities. And I said, even in the management of these facilities, we have given the community to be in the board, and they are the ones who will be running. In as much as these are public facilities, they are the board of management for level 2 and 3. And we have ring-fenced their money. There are many changes that have happened. NHIF was not also a bad thing. It has done a lot in terms of addressing the healthcare financing aspect. But what we needed was to improve. And to improvement, instead of amending every section of the act, we just created a new, and we gave extra benefits. For example, emergency was not available. Emergency as a right was passed in the Constitution in 2010. From 2010 to 2014, it has never been actualized. This is the first time we are daring and attempting to actualize that right. And we are saying you don't even need to have registered for you to benefit from emergency. Under NHIF, you had to be a member, number one. 2, you had to have contributed for you to get any services. It was similar to any other private members club, where you needed to be part of it for you to benefit. Under SHA, for the primary healthcare fund, you just need to register for you to get primary healthcare services. That was not possible under NHIF. The law did not allow it, and there was no tax fund that was coming to it. It was just members' contribution, and they were using. Benefits were given only to members. That was not possible under NHIF. But for now, SHA, we have the primary, we have the emergency chronic critical illness. The second thing you need to realize is the chronic critical illness fund is also meant to address excess loss. Those who understand the insurance language. So you exhaust your shift contribution benefits. Then now you need, because you have those two conditions, critical and chronic condition, then you need someone to look after, who better than tax-funded money? So that's why we have under SHA, we have a mixed model of funding, contribution and tax coming together to provide services. 3, NHIF had an open check on administrative fee, because you could spend as much as 20% of what you collect. SHA does not have that luxury. It's in law that we can only use 5% as administrative fee. 95% is for members' benefits. So it is, and it is meant to be, it is output-based financing mechanism. You provide service, I pay. A patient or a client has to get a service for us to pay.
Yeah.
So we don't have the luxury of spending 95% of the money for anything else other than tied to a service. And that service is for Kenyans, not for anyone else.
All right. I see the question of their third rule keeps popping back up. And, maybe just shed some clarity on it, because I see quite a number of people on the chat getting quite a bit on the mathematics there and wondering about the law, the third rule law, and the fact that a number of, quite a huge chunk of the amount is already.
So I think on that, I have to get HR experts, because I'm not one. And I will actually, now that is something that has come to my attention. I will also consult with my team, and then we hear out what are how do we address that kind of challenge.
That's all right. So there will be further consultation on the issue of their third rule. And when we hear about it, Dr. Abdi, I'm hoping we'll be amongst the first ones to hear. Then we can share with our team. The other question, and just going back a little bit on the chronic medication, the questions that keep recurring, and I know you've spoken into it, but just to reiterate so that those who are still asking can get more clarity on it, is chronic medication fully covered? That's number one. And then people with dependents who have disabilities, their registration, because many of them cannot register for themselves. Those over 18 years old who have disabilities or living with disabilities. How is that going to happen in terms of their registration? And then the implication of selecting the wrong disability, because only 3 disabilities have been listed. So what happens if you register the wrong disability, for example, because your disability is as a result of a chronic condition, for example?
So for disability, we have given that because there is a government body that is concerned. We don't dictate what kind of disability you need to come up with. So as long as you have that disability, yes. On the issue of chronic, I think what we need to look at is there are 2 things that we have tried to do. Number one, the issue of trying to address preventive through screening. But the second thing that we have done for chronic is we have decided to pay for specialized lab services, especially for diabetes, for hypertension, for asthma. This is just a beginning. Subsequent financial year, our idea is also to push a pharmacy benefit as one of the benefits for chronic condition, which will address the medication for these chronic conditions, so that we have clients, we have the testing and we have the medication, but more importantly, we also have the screening in place. So that will come in the. But there's one other chronic treatment that we have also addressed, which is the post-transplant medication, up to the limit of 200,000. And this we will take up with the manufacturers and see whether they can fit into this so that the patient does not have any extra payment when it comes to the post-transplant treatment.
Thank you. Thank you so much for that clarity. I think the other question that keeps coming back, is on supplementing the private cover. There's already private covers. So what is the benefit, the full benefit schedule? I know, Edwin, we had agreed that after this we will share, if you allow us, the full schedule of benefits so that we're not having to discuss this again through this, because it's a wide schedule. But maybe you can touch on a few on how that complements each other, especially with the transition. Yeah.
So what we have agreed on is SHA is your first payer. That is guaranteed standard. So if you get admitted to a hospital, so it's what services you need. So sometimes you need surgery, and that surgery is listed. You will get that benefit fully covered. Then you will top up depending on the facility that you have gone to. Then you have normal medical admissions. You will get your bed rebates. Then you have normal investigations, CT scan, MRI, radiology. You will also get your benefit. You need maybe dialysis. You will get the full benefit. You need investigation for cancer treatment, the specialized lab tests. You will get that. You need radiotherapy. You need PET scan. You need cyberknife. All that's covered under the benefits. So what happens is, in anywhere you go, there's that fast charge. So whatever SHA is you're entitled to is what you get first. Then now, if you need to top up, you will top up. If you don't need, then you will move forward. But as long as you have your contributor for SHA, then your benefit you're entitled to. The second thing is that benefit and tariff is a public document. And it's a document that we will update every 2 years. And there's a whole committee that has been set up outside SHA, which even has the public sector and the civil society as members. And individual groups can also petition and say, please add this benefit, please add this tariff, increase this price. So it's a public document that has public participation, and it's a continuous document. It's a living document that will be improved regularly. It's not cast in stone.
So I think what I get to hear from Dr. Abdi is that they have published a schedule of tariffs that will be applicable when you're accessing services under the SHIF benefits, and that the SHIF benefits are accessible by members who have subscribed by paying their 2.75 or through the mean testing contribution that would have been determined. Therefore, it means that once you are a subscribed member and you've paid, then you're entitled to the tariff, what the tariff provides. Now, depending on the hospital you land in, the tariff could be sufficient to cater for your medical care or may require a top-up. And that's why we say that the private health insurance will come in handy at that point to be able to bridge the gap between the tariff and what the hospital charges.
Yes.
But for a large majority of the lower level hospitals, level 2, level 3, and some select level 4 hospitals, the tariffs might be sufficient. So our role as insurance practitioners is to really delve deeper into the tariffs and to be able to advise our clients on how to structure the medical scheme for their members so that they can optimize the benefits under SHIF and also save costs on their medical schemes. And in due course, because of the improved claims experience that we anticipate, if the SHIF benefits do come through for our members, is that then we expect the medical costs to reduce, or that we'll have the privilege to expand the offering to members.
So you can increase the benefits. Instead of telling people go to private, in the general ward, you can tell them go to Princess Zara. You see, those are now extras that people want.
Some of the conversations that we have when we have an actuarial analysis of the costs, yes. Once we can clearly see the difference between the two. But thank you so much, Dr. Abdi. I see a number of our clients have their hands up. We were not going to allow us to speak because of the number of people on the call and the dynamics of this, and our time is really spent. But I'll give two people an opportunity to just say, I've been requested by public demand. I see my phone is going off the hook. So Winkate, maybe help me to allow two people to quickly.
Please allow me. I stand for the payroll processors, please.
That's all right. Please proceed. Introduce yourself, organization.
Thank you for that. My name is Paul. I deal with payroll processing. There's a question that I posted on the chat, and I think I felt I can't let it go before we get maybe a clarification. Number one, we know SHA is based on gross pay, gross salaries. So I just wanted Dr. to mention to us, there's no definition of gross salaries in the Act. Maybe to just mention, does it include bonuses? Does it include terminal payments? The other one is, will we have a deduction in SHA similar to what we had, a relief in SHA similar to what we had in NHIF? And the other, when will SHA gazette the bank details for employers to be able to pay? Up to now, we don't know where we are supposed to pay the deductions that you are going to remit from the employees. And maybe to Dr. one final one, on the ADHAD rule, you'll notice that most of the employees are on the verge of ADHAD due to the hard economic situations. So even if you increase even 500 shillings to these employees, most of them are getting defaulters from the bank. How maybe from the government, probably you can have an engagement with the stakeholders and see how probably you can be able to introduce, even if it's a reduction in terms of finance bill, probably it is coming. Thank you.
All right, thank you, Paul. I know Daktari had already responded on the third rule. He will get clarity and come back to us on that one, but maybe just a quick response to the other two questions. On the gross pay, is there a definition? Is the relief still going to be there? And when are we gazetting the payments, the details for payment?
The details for payment is even on our Twitter handle. And I think that document has been circulated. But when you go to the portal, and you will also find the same on how to upload, and the payment, the bank details are clearly in that portal. But we will be able to now continue publicizing. I think we have published almost 8 bank accounts, if I'm not wrong. Then the issue of, I have said I will have to ask on the issue of third. On the issue of relief, yes, the relief still applies the same way. Although we wanted a bigger one, which was supposed to have been done under the finance bill that went out, yes.
Right. And the definition on the gross pay? On the gross,
of course, the bonuses are not part of
bonuses.
It's your day-to-day salary that is the gross
minus the bonuses.
Yes.
All right. Yes. I hope that's clear.
Yes, somehow it's clear, but maybe we'll require probably a definition so that in case we have an audit from SHA, we can be able to point that this is the definition of gross. They have directed us we should not include things like bonus, terminal, final dues, and things like that. Please, Dr. if you can be able to assist us. You're on the edge.
We'll do a communication from SHA to employers.
Hopefully before the end of this month, before you finalize the processing, please.
Of course, definitely.
All right.
Thank you. We'll appreciate as HR and payroll processors.
Thank you so much, Paul. Margaret Gishinga, you can go next.
Another time.
Thank you. So I think the question about the refunds on the bed rebates was not very clear, because we're asking about the patients who've already paid for the bed rebate. How do we go about the refunds? And number two, for someone who's getting admitted, say this week or the coming week, will the bed rebates be paid by SHIF?
Yes, for someone who has admitted, the bed rebate portal, that tab is now active and it's working. For those who have paid, it will depend on whether the facilities will do the manual claims. If they do, then they are the ones who will refund you. We will pay them because it will be very hard to pay each individual client. But we are waiting for facilities to give us their manual claims over the last 2 weeks, where they were doing manual claim processing. And once we address, we will be able to say, tick and pay to the facilities. Now you follow up with the facilities in terms of refunds.
Okay, so it's a follow-up with the facilities. Individuals who had paid cash out of pocket can follow directly with the facilities for that. I hope that brings clarity to all who are asking and have already paid during that season. Winkit?
Yeah, I think we'll just ask one final question. I do note that we really are way above the time we had planned to take. So, Daktari, could you kindly explain the process of onboarding the dependents? Are children over 18 years covered? System asks for their ID and then says the ID cannot be verified.
So children who are above 18 are covered and as dependents, but the ID that you need to upload is the ID for that they are engaged in education. That's college or university. And that's the one that you use now to upload and say, these are my dependents and they are in school. And that is up to 25 years.
Okay.
Yes.
Okay. All right. Thank you so much. There's one more question from Lydia. Okay. Oh, that was it. All right. So thank you so much. I know our time is much spent and we've really not exhausted the questions. I see still a lot of questions on the platform, but we appreciate your attendance. We appreciate that you've been here with us. And Daktari has graciously accepted to continue this conversation with us next week. So we will look out for the webinar details. We'll have a better control of our system and then the network we use, the virtual platform we're using, so that we have better conversations and a better experience. We apologize for the hitches that have been experienced during this webinar, but we promise a very, very good experience in our next one. And Daktari has graciously accepted. Please look out for our invite for those. If you can share with us your questions in advance, that would be really appreciated, so we can curate them properly and have a structured conversation with Daktari to respond to most, if not all, of the questions that you're asking. But of course, we'll go through all the questions today to ensure that an adequate response is given during our next meeting. So thank you all so much. I'd like just to quickly wrap up. I allow Edwin Kegode a minute and Dr. Abdi 1 minute to just give us, your final quick shot that we go away with to remember from an insurance point of view. What is it that you would like our people to remember?
First of all, let me take this opportunity to thank all our clients who have been able to join in on this session, and also thank Dr. Abdi sincerely for just sparing this time and honoring us with his presence to be able to allay any challenges that people have with regards to the SHA and SHIF benefits. From an insurer point of view, I think we have come of age as a country to be able then to graduate our health insurance offering from the government perspective, and as practitioners, for us is to be able to study in detail the benefit offering, as I said, the tariffs that have been granted by SHIF, so that we can then advise our clients appropriately with regards to their medical scheme programs. We see a lot of complementary benefits that are coming through from SHIF. What we urge SHIF, and who better to ask than the chairperson, that we need to see a difference in the delivery of services, that we promise that when there is good delivery of services from the SHA and the SHIF benefits, then the insurance fraternity will be more than glad to be able to make adjustments to the programs that we run for our clients, and ultimately offer better services to our members, and in so doing save some costs, and where possible enhance benefits, so that the members enjoy healthcare benefits when they need it.
Thank you, Edwin.
Okay, thank you very much, and we will get clarity on the few issues. I know it will take some time before people adapt and understand fully, but you will realize with time that this is beneficial to everyone, whether they have been contributing or not contributing. And we are trying to address the whole challenge we have in the health space, which has been the silos in terms of data. You have private sector that has its own data, public sector, patient records are scattered in different places. There's no continuity of services. No one knows. There's no now connection on where the patient health is concerned. So by addressing the challenges in the industry, we hope it also benefits the private sector, because a more properly governed healthcare system, especially by removing facilities that engage in fraudulent activities, will be beneficial to the private sector as well. By also being the first payer, it means we are willing to take our part, which is we are social health insurance. And that's the one thing that I want people to understand. You could be employed formally today, running payrolls in the hundreds of millions, but tomorrow you could be the one who is jobless outside. So don't look at what you are contributing today, but look at how that benefits many other people, including yourself in the future, because no one works forever. A time will come that you will have that luxury. So a few things just for them to tell their relatives as well. They just need to register for them to access primary health care. And if they finish the means testing, they are able to pay, then they will also benefit all these other things. We don't have any exclusions, we don't have any age limit, and we don't have any waiting period. So access is immediate. Sometimes you could be even at the hospital level. Instead of paying 10,000 cash, you are better off enrolling. And that's the culture we want to inculcate in our country, that prepayment is cheaper than getting services on cash basis. Thank you very much.
All right. Thank you so much, Daktari, for taking the time. And thanks to all of you for joining and staying with us. All your questions, we will make sure they are answered. If they've not been answered satisfactorily during this webinar. And like I mentioned earlier, we'll have another session that will offer a better experience. We know that this might not have been the best experience because of the platform we used, but we will definitely have another session and shed light on some of the things that we were not able to complete today. So thank you and have a very, very good morning, and God bless you. From us here at Minet, we don't take it for granted. Thank you.
Thank you. Thank you.